My name is Dr. Julius Gardin, and I'm a professor at Hackensack University Medical Center and Rutgers University. And my invited lecture dealt with the use of carotid ultrasound as a measure of subclinical heart disease. And the reason that we look for measures of subclinical heart disease is that we know that the traditional risk factors, such as those developed by the Framingham Heart Study, aren't perfect indicators of who's going to have a heart attack or a stroke. In fact, we know that about half of the people who do have heart attacks and strokes using the traditional risk models are in what's called low or intermediate Framingham risk categories. Carotid ultrasound is a relatively easy measure to obtain. Usually using sonar, we measure the thickness of the intimomedial walls, either in the common carotid or the internal carotid arteries. And there have been any number of studies that have suggested that it's a good measure for who is going to have heart attacks and strokes in the future. For example, I was involved in the cardiovascular health study in elderly individuals. And even in that group, if you had the lowest fifth of thickness of your carotid intimomedial area, you had a 95% chance of not having a heart attack or stroke over 6 to 7 years, whereas if you were in the highest fifth of that group, you had only a 75% chance. There have been other studies also, such as the atherosclerosis risk in communities, that have shown that adding carotid intimomedial thickness measurements can help reclassify these traditional Framingham risk groups, better classify them into higher or lower risk just by adding that. And there have been other studies, such as the Café's Cave study from Italy, that suggests that if you also look for intimomedial thickness in the femoral arteries, that will help you pick up more individuals who are going to have a cardiovascular event. So that's all well and good, but one of the key issues is, can you use carotid intimomedial thickness to predict who's going to respond to a treatment, and is that a good surrogate measure for who is or isn't going to have a heart attack or stroke? And I think that this is the niacin story is a very interesting one in that regard. And just to highlight a couple of milestones in that, there was a study called Arbiter 6 Halts, where folks who had well-controlled LDL cholesterol and who had coronary heart disease or coronary heart disease equivalents were treated either with ezetimibe or with extended-release niacin. And it was shown that the extended-release niacin decreased the carotid intimomedial thickness, and there was a dose-related response, whereas the ezetimibe increased carotid intimomedial thickness. So this looked very good for the extended-release niacin. However, this was followed by a trial called the AIM-HIGH study, which was stopped 18 months early, because what they found is that even though adding the extended-release niacin reduced the HDL, reduced or increased the HDL cholesterol as it was supposed to do, it did not decrease cardiovascular events. In fact, there was a small signal that it might have increased stroke. So here you have a situation putting the Arbiter 6 Halts and the AIM-HIGH trials together, where the niacin seems to decrease carotid intimomedial thickness, but may be associated with no decrease in cardiovascular events. Now, this niacin story was contemporaneous with this. There was a meta-analysis of the Medline and Cochrane databases that looked at all studies that used cardiovascular treatments to decrease cardiovascular events, and also included carotid ultrasound intimomedial thickness in the measurement. And this was included about 18,000 patients in 41 trials. And what they showed is, although the treatments by and large worked to decrease cardiovascular and cerebrovascular events, there was no relationship between the decrease in carotid intimomedial thickness and a decrease in these events. So even though the last American Heart Association, ACC, guidelines on preventive cardiology suggest that it's reasonable. It's a 2A level B indication to do carotid ultrasound in individuals who are at intermediate Framingham risk for events. One should understand that it adds slightly to your risk prediction, but we cannot rely on it to necessarily tell if treatments are going to decrease cardiovascular and cerebrovascular events.